So we have a presentation from 2 Tribal Epidemiology Centers on their experiences with the Tribal Data Learning Community Program, or TDLC. The TDLC is a 1-year pilot program from the Centers for Medicare and Medicaid Services to allow researchers at TECs, that's what we call Tribal Epidemiology Centers, to use CMS data for community needs. So here to present on their experiences with this program are Dr. Ming Gong and Dr. Cheng Wang. And Dr. Gong is a biostatistician working with the Albuquerque Area Indian Health Board. And Dr. Wang is a biostatistician working with the Great Plains Tribal Leaders Health Board. So please welcome them.
Good morning, everyone. My name is Ming Gong, and I work at Albuquerque Area Indian Public Health Board. Let me see how it works. Okay, yes. So in my presentation, I kind of want to go over some of my experiences last year working with CMS data. I started working at Albuquerque Area Indian Health Board last year around this time. And then our director, Kevin English, assigned me, one of the projects that he assigned me is to work with CMS data. And so I just want to go over some of the things that we went through, and then the TDLC's kind of purpose and role in helping us understanding the data, and what is our tech centers role to this process. And so and I did get some results, some basic results, and kind of one of the things that when I was working on this is like, what can we do about this data? Now I see when I just get into it, I see all of these data files and different columns and so many different files and different folders, and I really don't know what's going on. It's this quite complex data set. And so so finally, kind of like after a year of like kind of training, I have some basic understandings. And one of the things that is in my mind is like, what can we do about it, right? And then I want to talk about it from my perspective, and then some future work and next steps. Okay, where's the? Okay, is it okay? Is it where? See, no, this is. Okay, sorry. Oh, well, it's going. I'm trying to going back. Wait.
There you go.
Oh, okay, yes, okay. Sorry, I'm going. Yeah. Oh, yeah, okay, that's first one, and then want to press it. Oh, okay. So first, to get access to the CMS data, there's a process, and kind of like from different like tech centers, I think we have different kind of like approval process. This is a basic framework. For me, our director kind of get this done pretty quick. So I have access to this data set about like 2 to 3 month period since like April. And I heard some other tech centers, they have like take like about 6 months or something all the way, even longer to have access to this data. And so it's a long process from different kind of like boards and approvals. And so, but these are the steps to take to get to this data set. And purpose of this tribal data learning community is that they kind of provides us some of the trainings and some background information of what we can do about this data. And so so these are kind of some of the things I summarized, the purpose and of the TDLC. And next slide. So first, I think in the first 2 months we have like bi-weekly trainings. Like it's like every month we have one session for the training, and then second half of the month we have like a tutoring session where we have like focus on one-on-one questions, you know, like mentorships. And and part of this, I think is very useful because this data set, when I get access to it, I feel it's very complex and it's really hard to understand what's going on, terminologies, on top of the technical kind of like difficulties, right? And so someone who is not trained with, SAS or R or Python, is, like you have to learn those things first. And on top of that, right, we also had to learn this new platform and, how to, access to this data. And there's so many files, and it's not just like one simple summarized file where we can do all kind of things. And so we have to kind of do a lot of manual work to do that summary. And I also, from our director told me like to put the slides to summarize what is the promise of tech centers, and so we'll have access to the CMS data. And so I summarized some of that here. And for the next slides, I kind of want summarize some of the, part of things like I want to talk about later as challenges to go through this process, not just kind of like the technical part of it is already hard, but there's other things, challenges where we also have to follow policies and protocols. And those to me is kind of quite difficult to do like kind of comprehensive analysis on this data set. And so that's kind of what I want to do next one. So part of that is the feedbacks, not just from me and also from other staff members that I work with. And there's a lot of this analysis. What I notice is it requires a lot of the menu coding. And so in order to grab some information, it's not quite straightforward. And it's like there's so many layers of protocols and also difficulties as well, technical difficulties as well, to kind of put together a summary of the data. And I used to kind of work on like large data set where I have a lot of control to kind of like what I'm working on. For this platform is there's a lot of protocols we have to follow, so we don't have fully control. We have kind of what I see is like follow so many steps and have like we have limited control, and so that kind of make it coding very, very hard. And so at least from my perspective. So so I summarize some of that here. So I kind of just kind of like did some kind of like screenshots, kind of show you what are the things we have to go through to kind of like at least to download the data set. And there's also a lot of requirements on like the data sets. First, we cannot have like download anything like larger than 1 gigabytes. And so if we have now, if I want to do a comprehensive analysis for across years and different states, and it's like that's like bigger than 1 gigabytes, and their approval process is pretty strict. And so so first you kind of create this, and you can see like and also like I think every week you can only ask like submit like a few files. And so I have to, in order to get what I want, is kind of I have to iterate many, many times. And sometimes I got the wrong thing, and then I had to wait for another week. And then they also take about a few days to review. And so those things are kind of one of those are the challenges that I have when I work with the CMS data. So those are the kind of like some examples of, and it's kind of they tell you email why you cannot access to data. And one of those, I kind of, this is just kind of like my personal Excel. I just create an example. Some of those things is like if you have something like a value, a cell value that less than 11, you cannot access to, you cannot down like, but that's a rule. If it's less than 11, you cannot access to the data. And so that's kind of, we have to work around this. And some of the Indian populations, which I kind of interested in, is extract information from the Indian populations across different states and study the chronic conditions. There are about 30 chronic conditions in the CMS data. And the population, some of that is very small. Like diabetes in certain states, I mean, literally there's like only like a few. And so how am I gonna, like how I'm gonna download that data, because is part of that is, that's the protocol, like we cannot access to that, and then right, and so, and also privacy things, like everything has to stay in that SaaS environment. So if I cannot download that information, like it kind of like all the code I developed to produce that result is, I probably have to work something different, and I haven't figured out a solution for that yet. And that's part of the things kind of I'm gonna have discussion today later on how we can work around that issue. And in terms of TDLC, they provide support, and they just send an email, like, they gave me some advice on, what I need to do in terms of those challenges from their perspective. So there's just some examples of just one experience. So some of the results I got, I was like, the question I had when I was working with CMS data last year is, what can we do about it? And because, we work with tribal communities, and first thing I was in my mind is like, and I want to extract, all of the populations from, like the AI/AM population, the nationwide, and also we serve Southwest states, New Mexico, Colorado, Arizona, and Texas. So I first want to extract those information, and then there's our like 30 chronic conditions attached to that, and like some of our staff members study, like diabetes or whatever other things they do. I can work with them to extract that information and study those do some research in those areas. And so this is kind of what I first, I only, so far I only, up to like last week, I only have access to the data up to year 2022. And so I was trying to see, like what is the AI/AM population in the Medicare data set, right? And so so that's kind of that's the first thing I extract. And I guess the data is pretty consistent up to 2013, and there's data before that where my code doesn't work. I think it because the data format is different, and so these are the things I can write like a script where I can automate, just kind of generate this stuff like by clicking the button after write scripts. And so this is what I found is like, kind of first thing is, what is the population across years? And that's kind of that's the result here. And I'll generate like a chart and see over the years, what is the kind of the changes in population. And part of this is we can actually, with this information, we could, extend this analysis to study across years of different chronic conditions among the AI/AM population. So this is overall the nationwide AI/AM population. Start 2013 and then 2022. What is the population? And next one we live in Albuquerque, New Mexico. So that's the state we serve the most, and so that's the population. It's pretty small. You can see it's really small compared to the whole Medicare population size nationwide. And I also summarized the Arizona. New Mexico, Arizona has a little bit more. The population is a little bit bigger than Colorado and Texas. And Colorado, Texas is pretty small. It's only a few thousand. Is the Texas. So so these are kind of the preliminary results that I have. And so yeah, anyway, so in terms of future work and next steps, and it's because I'm pretty new on this, I just kind of shared my experiences. I work a lot of large data before, where I have relatively like a full control. And I think it's like from my also like communication from other sub members is these are things I kind of like summarized for the challenges in future work. If we can have a little bit more streamlined approval process, like make our time, the interval where we can access the data a little bit quicker and the approval process a bit quicker, that would be nice. And another thing I kind of want to see is like a lot of this work we have to do from ground up. I feel like some of this work can be modularized, where like I can, if I derive, I want to study certain populations. It will be nice that they already have like sample code in place where we just do a little bit modification instead of like, okay, read all of this articles and documents. And it's not very easy. I mean, sometimes take like, I'm not kidding, it's like take a month to just read through all of these documents, understanding the meanings of each columns. And then there are so many files that is relevant as well, which file that we need to go into. There's so many of them where in the end easily can get lost. Like, you can grab something that is actually maybe not as relevant as what you want. So so it would be nice to have that, like sample code that is already in place, someone work on something similar, where we can just like borrow that code and then modify that a little bit and to do that work. And so that's kind of the things in my experience to kind of my challenge. And as conclusion, and I think this is really important. Data set is huge. And like people talk about this like a lot, is like, is we can really utilize this to do a lot of studies. Sometimes if you diabetes, like you may not have enough population size, right? And this is part of that. You can actually grab that population and enhance your study. The training that we have, the TDLC training, is super important too, because without their support, I don't think we can get this done quickly. I mean, even that, we still take quite a lot of time to get approvals and access to this data. So, so those are the things I have for today. Thank you.
Good morning, everyone. My name is Chen Wang. I'm a biostatistician with Great Plains Tribal Epidemiology Center. I'm honored to be here to share our experience accessing and utilizing the CMS data through the TDLC project. So first of all, a little bit introduction about our organization. So we are one of the Tribal Epidemiology Centers. Our main office is located in South Dakota, and we serve 19 tribal communities in South Dakota, North Dakota, Iowa, and Nebraska. And this is our timeline accessing and utilizing the data. So in July 2023, we learned about this opportunity for the very first time in an initial meeting with the TDLC technical assistant team. And then the following months were spent on just reflecting on the opportunity, doing our homework, having our internal discussions. Honestly, we had mixed feelings about this because I'll talk about it later, because we have to access this data through the research pathway. And then towards the end of 2023, we had a clearer timeline for submitting our application. So, but the deadline kept shifting. Then in November 2023, we finally received our final deadline, and we needed to submit everything by December 1st. Which really left us a little time to prepare. But thankfully, we were able to submit everything with the help from the TDLC technical team. They basically prepared everything for us. We just mostly reviewed the documents and filled in our tax-specific information. During the application process, the biggest challenge was the IRB review process. As mentioned, we only had little time to prepare the application package. However, our regional IRB board had a significant backlog, and they review proposals relatively slower. So that no way we can make it by December 1st. And then luckily, we were able to submit our application, IRB application, to the Indian Health Service National IRB Board right before their next review meeting. So we received our approval 2 days before the deadline. Whew, right? But in the we can definitely see in the future for tribes and tribal organizations to access CMS data, this will be a significant barrier, right? And IRB actually is for reviewing research projects involving human information and human materials. We are public health authorities. We do public health services. We are not conducting traditional research. Then that leads us to the question, why did we need an IRB review at the beginning, at the first hand, right? That's because there's no readily built available pathway for tribal organizations and the tribes to access the CMS data. So on the application form, there are 4 pathways. Number 1 is academic and research pathway. Number 2 is for-profit organizations. Number 3, state agency. And number 4, federal agency. So there's no readily built pathway for tribes and tribal organizations. This is definitely something that needs to be addressed. And I also know that other TECs also had a lot of difficulties during the IRB review process. One TEC got denied by their IRB board because it's not a research project, which is a valid reason, right? It's not a research project, so their IRB was not able to review it. So, and then that's the initial application. And then from April to June 2024, we received necessary trainings, guidelines. We set up our data environment. We finally gained access to the CMS data. And then after that, we spent 3 months familiarizing ourselves with the data structure. We attended trainings, office hours. And then by October 2024, we feel we finally are ready to explore this data further. And we had meetings with our tribes and brainstormed a lot to identify priority projects. Ultimately, we decided to work on a maternal health report among American Indian Alaska Native women in Great Plains area as our first project. So some success stories and achievement. So in year 2024, we heavily focused on the training. So our team attended more than 40 trainings, and 5 data set holders gained access to the CMS data and have been actively analyzing the CMS data. We have received 3 TA requests from our tribes. One is related to opioid overdose screening, which have been addressed, and then 2 ongoing requests on dialysis and dementia. As mentioned, we are working on the maternal health comprehensive report among our community. And on top of that, we really don't want to purely do the fancy analysis and which never goes back to the community. So we are also writing a grant trying to utilize this data for community intervention to increase syphilis screening among pregnant American Indian Alaska Native women. Challenges, we already talked about the the lack of application pathway for tribes and tribal organizations. And then second challenge, as mentioned, Ming mentioned, the data set is super complex. It's highly complex, hundreds of elements, many tables. On top of that, the history policy changes also add another layer of complexity. If you don't know well about the policy changes regarding to the CMS data, you might find yourself very confused looking at the data. And then another challenge is the sustainability. So this data is expensive. Right now, we are very grateful we have free access to this data through this pilot project. However, out of this pilot project, the regular data access costs more than $100,000 per year for data sets. So that's a big financial burden. So we would ask CMS to collaborate with the tribes and tribal organizations, maybe on a long-term plan to help us to have the continued access to this important data. And then my takeaways. So is it doable? Yes. There are challenges, definitely has gap in process and data, but it's doable. Does it worth it? I think so. So this data is highly complex. It might contain a lot of answers to many questions from our tribal community. Plan for at least 2 or 3 years for the initial stage to wrap up your initial projects and then have some comprehensive products. And then one of the biggest future step might be discussing how to make this access sustainable for tribes and tribal organizations. Yeah, with that, I'm ready for any questions. Thank you. You want to sit or do you want to stand here? Yeah, thank you.
So I first ask if we have any questions from the audience about the TDLC or anything that we heard presented. Otherwise, I do have some, but I'm happy to first turn it over to, so we'll go here and then here.
So I just wanted to say
Can
thank
you use the mic?
Oh, sorry.
That's okay. Just, we want to make sure everybody online hears.
No, I just wanted to say thank you. It's interesting to hear the researchers' viewpoint, because a lot of times we'll sit at the table, we'll see kind of the products in between the process there, but not necessarily appreciate maybe all the work that goes into it. So thank you.
Hello. I also want to say thank you both for those presentations. Those were wonderful. My name is Jasmine Hall. I am an epidemiologist with the Michigan Department of Health and Human Services. One question that I had for both groups is around people who might identify as multiracial or multicultural. What did that look like in your data analysis and data cleaning processes? And then my second question is for the Albuquerque group. What did it look like with your engagement with the tribe? I heard a lot of from the Great Plains group about how they worked with the tribe to identify questions and opportunities to develop programs afterwards. But what did that look like for you all as well? Thank you.
Thank you for the question. I'll take the first one, and then Ming can share your experience about tribal engagement. So regarding the race ethnicity data, honestly, it's well known that there is a race misclassification issue in the CMS data set. So it's not perfect. And then for their Medicare data, they have several categories, including white, non-Hispanic, Black, non-Hispanic, American Indian, Alaska Native, extra. And there's one category that is multiracial. So which means we are probably not able to identify these individuals with the multi-race on their records, and also are American Indian, Alaska Natives.
That makes sense.
Yeah.
Thank you.
Yeah, sure, absolutely. And then also related to that topic, some of the techs also have access to the EDM data from the IHS service. So EDM data is like the epidemiology data mart. That is from the electronic health records from Indian health service facilities. So that one is the race data is more accurate because mostly like more than probably 95% of the individuals who utilized Indian health services are American Indian Alaska Native people, right? However, for that one, the problem is that we don't have the data for other race and ethnicity groups. So it's hard to do a comparison. Sometimes we want to see how we are doing compared to other groups, right? Yeah.
Thanks.
Yeah. Yeah. So for us working with, I think Eudora can answer me a little bit better, but if I have something you want to add, you can add it. I mean, I kind of new to our organization, but my experience is that, you know, we also take the community-based approach where we actually have our own local data, store our own like drives, secure drives, and we do talk to communities and different tribal communities, and we we set up meetings with them and like collect data from that way, and also a lot of high school students as well. So a lot of our data is community based, but they don't have a lot of like the data set is not as large as CMS. The small
Yes,
communities, some of them are like it's only maybe 30 members, something like that, and so yeah. So that answer your question or?
Partially. So I was more thinking about specific to the CMS project. Have you gotten to that stage of, doing TA requests with the tribes or that engagement specifically with the CMS data, since that is the most, rich and comprehensive data that it seems like you have access to?
Yeah. So part of the challenge that I face is, let's say we want to study diabetes, which I do have the code. I have some issues with that. First of all, the data is not very clean across years on the chronic conditions. Some of the values in 1 year is like character is like those values. One is character nature, and the other one is numerical other years. And so it's hard to kind of write a script that kind of, and I probably have to do some extra work to kind of clean that up a little bit. That's one of the challenges. The second challenge is the population. When we are actually dealing with chronic conditions, I was looking at diabetes, for example, and some states really have very low number of the AIAN population is, first of all, is very small. And then on top of that, like when we study diabetes, for example, that one condition is even smaller. So the value is less than 11. When the protocol says if the value is 11, you cannot they don't let you to download the data set, even though in a summarized table. There is no personal identification whatsoever. But there's so many protocols involved, makes access to data really difficult. That's kind of what we're facing. Another one is we can only access download anything up to 1 gigabytes, and that's if we have something like this, like 30 gigabytes, we have to break it down to a lot of 30 times, something like that. So those are the things I face. We haven't been able to go across that barrier.
Thank you.
Thank you. Here in the green.
Thank you. My name is Janelle Palacios, and I have done just a little bit of work at TA for a National Center for Fatality Review and Prevention, talking about data. My question or comment is more like, it sounds like there's a great opportunity for the techs to collaborate on a code book together, right? Because if you're already doing a lot of cleaning of that data, Dr. Ming, then it's going to be, or Dr. Gong, it's going to be really important that as a team, the 12 techs come together and have an open source code book that they can share. just because it's so time intensive. I know that some of the work that I've done with a team in California, that they have been able to get around the suppression of data. And of course, it's because they are pooling 2 years together, right? But that kind of like one-on-one conversation with CMS, at least 6 months ago, was easier. I don't know what it will be in the future, but especially with the future that we're looking at right now in present day, it's going to be really important that the techs come together and share their code books and their resources. So techs who are here, maybe you should collaborate, exchange information on that.
Thank you for that comment. And I believe there were 9 techs that were involved in the TDLC. Is that right? 9, I think, who went forward. So there are not all 12, but 9 of the 12 did. So that's really good. Wow, we have lots of hands. Okay, I think I saw here first. Yeah. Can you please use the mic?
Thank you, Tamu. Good morning. My name is Carmela Roybal. I'm actually from New Mexico as well. The population is much higher. It's over 200,000. I'm curious about the composition of the CMS data. And because it's highly skewed, and I know that the majority are in CMS. I'm wondering if it's coded different, is this kind of like the turquoise tribal? The other thing is I don't think this captures all of the public and private hospital data, or it's misaligned. I also work with the Agency for Healthcare Research and Quality, and so HCUP and some of these other data sources contain a lot of this data, and this is not linked to this, and I think that's going to be really important in the future in order to paint an actual accurate picture. So I'm just curious about the composition, the low numbers in the CMS, because it doesn't match the overall population in the state of New Mexico. And as far as tribal, we all know the difficulties of working with tribal data and building sound data sets that we can really work across. And so I'm just kind of your thoughts on that and what you found, and then maybe we can have a conversation after. So kunawaha, thank y'all.
Yeah, so like the one I got is the Medicare. So it's like people's age is like, I guess 65, so something like that.
I was going to ask that. So the slide was for the population of people on Medicare.
Right. So that's the
Okay.
one. Yeah, I got is the particulars for the Medicare. Those numbers in Medicare, and yes, the accuracy, like based on the accuracy like that. To be honest, I don't have a good answer to that yet, because this is the only thing I have access to, and like that the information is there. I just write scripts to extract that information, and whatever the number I got is, I mean, it's kind of, that's what I what I have. But if there's other sources, like comparisons, then I can maybe answer that question better. But yeah.
We can't hear you, sorry.
So some of this data work has already been done and cleaned, the Medicare for sure.
Mhm.
And so that actually exists, but we can have a conversation after, and I can.
That would be great.
Yeah, so that's another thing I was thinking, is because a lot of this stuff, like we do not want to build this stuff from ground up. And if they have something like a scripts, like written there or something similar, that we don't have to go through years of trainings to kind of get to that point. And you're right. And that's a part of the challenge that what I faced here is it's not there. And then all of this stuff gave to you, and there's so many information documents, and you have to kind of do your own research to kind of figure out what's going on. And that just very time consuming. And it's good that we all kind of collaborate a little bit, and then so we don't have to, everybody coming in, is like it takes so long to move up. Yeah.
Yeah, I think that you're all in the initial stages, is my understanding of, because it has been such a learning curve. And do you want to say one last thing? We have about 30 seconds.
Yeah, I wanted to confirm that the Medicaid data, at least we are analyzing the maternal health Medicaid data. It seems the coverage is very high, because many of our American Indian Alaska Native women are qualified for Medicaid. And then, Janelle, I really like the idea of code sharing and the community practice. That's something we are thinking about.